Hey guys, Miss Hill here, and we're going to continue with individual module 6. We're talking about newborn care. This is PowerPoint 1, lecture 2. So we left off uh, regarding coagulation. We're talking about hepatic adaptations of the newborn. And from a coagulation standpoint, we know that newborns are depleted in terms of clotting factors um, that are vitamin K dependent. So, excuse me, they're not depleted of the clotting factors, they are depleted of vitamin K. And those particular clotting factors in our system that depend on vitamin K um, are affected whenever you don't have enough of that. So, because newborns are depleted in terms of vitamin K, they have a hard time clotting because of certain factors that depend on that nutritional component. So we give them vitamin K injections at birth so that we can promote clotting. If they didn't get it, they would be at risk to have a lot more bleeding and possible hemorrhage. There are also some other things other than vitamin K that can contribute to coagulation problems in the newborn. So moms who are on some type of therapy, um, like phenytoin or some type of phenobarbital, those things will cause abnormal clotting in the newborn, and you'll see an increase in bleeding in the first 24 hours after birth. Moms who are on any type of warfarin or Coumadin therapy, that can also cause the newborns to bleed because that drug crosses the placenta. Transient neonatal thrombocytopenia can also occur in newborns um, of mothers who have severe hypertension or HELP syndrome. And we know that the cure for HELP syndrome and severe preeclampsia in moms is delivery of the baby. So not only might we have the risk for that thrombocytopenia in a newborn of a mom who has this issue, but maybe this issue also occurred very early in pregnancy. So now we have a pretermer on top of that. Um, we talked about how the newborn system is very immature when it comes to breaking down and excreting bilirubin. Um, Newborns are not able to excrete bilirubin very well, and it builds up in their system, causing jaundice. Physiological jaundice in newborns is caused by an accelerated destruction of fetal red blood cells. Their inability or their impaired ability to conjugate that bilirubin that has broken down. So we have a lot of unconjugated bilirubin, which means it's not bound up to anything else or bound up to what it's supposed to be bound up to. Um, so we have this increase of unconjugated bilirubin that is circulating in the baby's system. And babies also have an increased bilirubin reabsorption from their intestinal tract. So to get rid of bilirubin, you got to remove it through the intestinal tract. They poop it out. But babies, unlike people with more mature systems, actually start to reabsorb this bilirubin in the intestines so it doesn't get excreted out like it would in a grown person. There are six kind of main factors that happen in order for jaundice to occur. There are increased amounts of bilirubin that are delivered to the liver. There is a defective hepatic uptake of bilirubin from the plasma, so the liver is not taking it in like it should from the blood. There's a defective conjugation of bilirubin, meaning it's not being bound up to the other elements it needs to be bound up to. And there's a defective excretion of bilirubin. So instead of pooping it out, they are reabsorbing it in their intestines. There's an inadequate hepatic circulation, and an increased reabsorption from the intestines. So all of those can interact with each other and puts a newborn at a greater risk for jaundice than your normal developed person. About 40% of full-term newborns will exhibit some type of physiologic jaundice on the second or third day after birth, and that can last up to 5 days. There's no real pathologic basis to that, and the yellow color that we see in their skin is present because of an increased level of that unconjugated bilirubin. Bilirubin is a yellow substance. Bruising, feeding patterns, gastrointestinal activity can all influence the serum levels of this bilirubin. So if you have a kid who has a lot of bruising from the labor process, maybe there was a vacuum extractor applied to their head and now they have a hematoma. Maybe they had a tumultuous labor and delivery and they've got some bruising on their face from coming through the maternal pelvis. So we have some red blood cells collected in a particular area, and the body is trying to break that down and get rid of it. And as it does that and breaks down those red blood cells, creating bilirubin, it's not conjugated like it should, and we have all this unconjugated bilirubin circulating in the plasma, circulating in the bloodstream. If the baby isn't feeding very well, then the intestines slow down. They're not excreting what they eat because, just like a normal person, if they don't eat or drink and have a consistent diet, their intestinal habits are disrupted. So it's the same thing in the baby. If we don't have a good feeding pattern and intestinal function is disrupted in some way, they don't have the ability to excrete this unconjugated bilirubin through their bowels, and it's reabsorbed. So that can all affect why we see this yellow color in their skin. Usually, signs of jaundice will start to appear after the first 48 hours of birth, and it differentiates in terms of time based on whether or not it's a physiologic jaundice or a pathologic jaundice. Pathologic jaundice is usually seen at birth within the first 24 hours. So you can think of physiologic jaundice as a normal process. It's a normal thing that can happen based on all of the adaptations of the newborn to extrauterine life. So their immature systems have an inability to excrete this bilirubin like our bodies do. So think about the 6 factors. Those are present in all newborns. So there's the potential for all newborns to have this physiologic jaundice if one of those little systems gets more out of whack. But pathologic jaundice, on the other hand, usually is caused by something that is more prevalent. And it's in response to some type of issue. Contributing factors can include hypothermia, hypoglycemia, maternal use of some medications, prematurity, and there's no consistent definition really of neonatal hyperbilirubinemia, but from a nursing standpoint, what we really have to be very concerned about is if they're starting to show signs and symptoms of jaundice of any kind, whether it's physiologic or pathologic, we need to get those babies, we need to monitor them more closely. We need to make sure that we get a bilirubin level, either transcutaneously with our TCB machine, or and if that is elevated, then we need to get a serum level, because what we want to prevent is that bilirubin from circulating in the system, building up in the brain, crystallizing, and causing kernicterus, which can be a or is a lifelong problem. So we don't want these kids to end up with brain damage because we didn't intervene appropriately. And the fix for hyperbilirubinemia is so simple, and it just has to do with light therapy. It is it is worth saying that some of our acute care environments may make it a little difficult to recognize jaundice. So if the lights are, the fluorescent lights can sometimes interfere with the way we see color. So we have to be very careful about assessing and making sure we're doing a good job of assessing that color and not allowing any of lighting problems. We want to assess them in a different variety of lights, and not just under a fluorescent light all the time, because we want to be able to recognize the color. An easy way to assess for the coloring of jaundice I've already talked about, but you just blanch the skin out, and you can press on the forehead or on their nose. And as the skin blanches, you see a yellow or an orangey undertone, and that's called icterus, and that is your nursey word. It is not described as jaundice whenever you document this problem. Jaundice is a diagnosis, so you would document that there is icterus. Newborn care to decrease the probability of jaundice includes doing things like making sure that you maintain their temperature. You want to monitor their stool for amount and characteristics. What color is it? What does it look like? That will tell you if they're excreting enough bilirubin or not. You want to encourage early breastfeeding for those individuals who are going to breastfeed. Encouraging early breastfeeding does a couple of things. Number one, it allows the baby to learn quickly within that first period of reactivity after being born, how to latch on. They're more awake, they're more able to feed for the first time, and it encourages their bowel habits to start. So it encourages the gut to start working. And also it does something for supply and demand of the mom. So the more you feed, the more milk you make. And the more the baby is pooping, the better chances that we're not going to get jaundice. If jaundice becomes apparent, we want to keep these kids really well hydrated because we want their bowels to move. And parents may need explanation and reassurance. They need to know how babies excrete this, because if the babies get home and they have a little jaundice, but now they're not pooping, they need to know that that could be an issue because they're not getting rid of the bilirubin like we want them to. Some babies that have some severe hyperbilirubinemia will be treated with phototherapy, and we can do that at home. And for really severe cases, we can do it in the hospital. So here's a picture of what phototherapy looks like. You can see overhead there is a Billy light, and this is just rolled across the crib and turned on. The big things to remember about phototherapy is that, number one, the skin needs to be exposed for phototherapy to work. But the eyes need to always stay covered, and the genitals need to always stay covered, because we don't want this UV light damaging gonads or damaging eyes. Newborns who are under phototherapy, parents need a lot of education to leave them uncovered. They need a lot of education to feed them frequently because we want those bowels to move. But they need education to let them know that once feeding is done and diaper changing is over, that their baby needs to go back under that light because we want them to spend as much time as possible under the light so that bilirubin is being broken down um, due to the phototherapy. It's very hard for new parents to not hold their children and to spend time bonding with them and doing some skin to skin. But it's really important for these kids who are under phototherapy because it is how we're going to get the bilirubin levels down so they don't end up with some type of brain damage. Also, newborns who are doing phototherapy are at a greater risk for dehydration. We're feeding them frequently, and we're hoping that they're pooping and peeing out this bilirubin, but their skin is exposed to a UV light, and um, they need to be assessed for dehydration. Breastfeeding jaundice is also a diagnosis. It occurs during the first few days of life in breastfed newborns, and it is typically related to inadequate fluid intake and not because the milk is not right. Um, breastfeeding jaundice is typically self-limiting. It peaks around day 3 and then it resolves. So let's think about that really quickly. Think back to how the breasts work after delivery and postpartum, and think about when milk actually comes in. Typically, your milk comes in around day 3. Up until then, you have mostly colostrum. So it's in a very small amount, it's very concentrated, and it will sustain nutrition, but it's not in a lot in terms of ounces. So when milk comes in around day 3 and the baby is getting much more fluid intake, then that baby will start having more frequent bowel movements, excreting more of the bilirubin, and typically you'll see that breastfeeding jaundice go away quickly. But for a breastfeeding mom who's having trouble feeding, the breastfeeding jaundice might not be self-limiting, and that kid may need some intervention. So to prevent breastfeeding jaundice, we encourage moms to give frequent feedings every 2 to 3 hours, even at night. Avoid supplementing the baby unless there's an issue. So, like avoiding giving formula and only breastfeeding. And that has to do with supply and demand. We want the mom to make enough breast milk to be able to continue breastfeeding and provide the baby with enough nourishment through nursing instead of adding in something. When you start to supplement your baby, your supply, your breastfeeding and your milk supply will actually start to decrease because of that supply and demand need. And then moms will need a lactation, probably a lactation consultant to come and see them as well for additional information. There's also something called breast milk jaundice, and breast milk jaundice occurs when bilirubin levels begin to rise after the first week. It's related to the composition of the breast milk and not the amount of the breast milk. And sometimes these people have to stop breastfeeding for a little amount of time. So two different types of breastfeeding jaundice. There's breastfeeding and breast milk jaundice. Those are two different things. Breastfeeding jaundice has to do with the amount that the baby is taking in and not the composition of the milk. But breast milk jaundice is related specifically to the composition of the breast milk and not the amount. So some key terms that you need to be acutely aware of are bilirubin and what it is, hyperbilirubinemia, which means just an abnormally high level of bilirubin that's in the blood. And you will see signs of this in terms of jaundice, and these you can also have some lethargy. Jaundice is an excess of bilirubin in the blood, and that causes a yellow coloration of the skin and the eyes and the mucous membrane sometimes, and may have to be treated. Kernicterus is a severe condition that occurs when bilirubin levels are so high that they move from the blood into the brain. And kernicterus can cause brain damage and permanent injury if it's not diagnosed and treated very quickly and in a very timely manner. So what about GI adaptations in the newborn? A term newborn has plenty of intestinal and pancreatic enzymes to digest most simple carbs, proteins, and fat. Proteins require more digestion than carbs, but they still can be well digested and absorbed in the newborn. Fats, however, can be digested, but they're absorbed less efficiently, and they are harder to digest for a baby. So that's why we don't need to be giving babies a chocolate bar or ice cream. It's not cute. Pancreatic amylase is the only enzyme in terms of the GI tract that the newborn does not have. They don't have it actually for the first few months of life. So they have trouble digesting starches. So I want you to hear that again. They have no pancreatic amylase. Pancreatic amylase digests starches. What is rice cereal? Rice cereal is a starch. So we should not be feeding rice cereal or starchy solid foods until babies are at least 4 to 6 months of age, because they do not have the enzyme in their gut to break that down. So when the grandma says that baby is hungry, give it some rice cereal at 2 weeks old, no, 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 grandma, no, because the baby doesn't have the enzyme to break it down. By birth, newborns have experienced swallowing, gastric emptying, and intestinal propulsion. So remember what they do in utero. They are swallowing amniotic fluid, they are excreting amniotic fluid, and their intestines are working a little. And especially if they've had some meconium in utero, they've definitely had some propulsion. Their salivary glands are immature at birth. Newborns don't produce very much saliva until they're about 3 months old. And then they start drooling everywhere. And it does not mean that they are getting teeth. It just means that now their saliva glands can actually start to make saliva. The newborn stomach has a capacity of about 50 to 60 milliliters. And anything above that is going to start to cause problems. It empties intermittently, starting with the first few minutes of feeding, and ends about 2 to 4 hours after a feeding. So 4 hours after they're fed, they might not have emptied everything in their stomach, particularly if they had a really large feeding. And if you look at this picture here, this is a picture from WIC. It's a pretty recent one. And it will show you the size of a newborn stomach day by day. Well, not day by day, but from day 1 to day 2. So we go from about the size of a cherry to the size of a walnut on day 2. And so this happens because of stretching. We don't feed babies 1 to 2 teaspoons every time. That's only 10 milliliters, right? We don't feed them that. Might not even be 10. So we do not feed them just 1 to 2 teaspoons of fluid every feeding on day 1. We usually feed them more than that. And that's okay for the most part, but you should understand that overfeeding them is going to stretch their stomach out, plus the fact that they do not empty their stomach as quickly. Um, and they also have the sphincters that are associated with the GI system do not work as well. They're immature and they're learning to do their job. So you're going to have babies who begin to spit up at every feeding if the moms and dads feed them too much. On day 2, it's about the size of a walnut and it can hold about an ounce. So that's about 30 milliliters. So we'd want to see them feeding around 30 milliliters at each feeding. By 1 week, it's about the size of an apricot. And that is not a peach, it is an apricot, and they are much smaller than a peach. So now we're looking at 1 to 2 ounces, so 30 to 60 milliliters. And by 1 month, it's the size of a really large egg. So we're looking at about 5 ounces they can eat at a feeding, anywhere from 2.5 to 5. When we talk about feeding babies, we have to educate moms regarding bottle feeding techniques and even breastfeeding techniques. So for bottle feeding, we want to burp these newborns often. We want to make sure moms and dads know that they cannot reuse formula. We want to keep the babies upright while they're feeding and keep the nipple full of formula and not half air and half formula, because then you're going to end up with a baby who's swallowed a lot of gas along with their formula, and they are going to regurgitate and start to spit up. Plus, they may end up with gassy belly too. That will cause pain. In terms of breastfeeding babies, we don't typically see the number of ounces or milliliters that they take in. We record the time that it takes to feed the baby and which breast that they fed on, and if they seemed satisfied after the feeding. And we also look at the fact that the newborn is exhibiting less feeding behaviors than before the feeding, and they're maybe less irritable, they're not crying, they're not suckling at their hands. And also, we want to make sure that they have plenty of wet diapers. So 6 to 8 wet diapers in a 24-hour period tells us that a baby is well hydrated. Not just a bottle-fed one, but specifically important to teach to breastfeeding moms, because they can't see what's going in, they can only assess what's coming out. So we can feel pretty reassured that if the newborn is having 6 to 8 wet diapers a day, that they are being well nourished from breastfeeding or any other type of feeding. Bowel sounds are usually present within the first 30 to 60 minutes after the baby is born. You should be able to hear bowel sounds. Their gastric pH becomes less acidic about a week after birth, and it remains that way for the next 2 to 3 months. Their cardiac sphincter and the control of their stomach is immature, so they don't have the ability to control those things like an adult or a pediatric patient. So oftentimes you see a lot of regurgitation in the newborn period, meaning spitting up. But we can teach parents to lessen that by burping them frequently during feedings and after feeding, and by avoiding overfeeding them too much. So teaching them the size of newborn stomachs is often really helpful, because and giving them examples like the cherry and the walnut, that is helpful, because if they can visualize it, it means much more than saying you can only feed them 5 milliliters or 10 milliliters, because that doesn't seem like a whole lot, especially when you see that in a little cup or in a syringe. They think they're starving their kids. Vomiting is limited in newborns. Continuous vomiting or regurgitation should be really watched closely, because there could be some type of anomaly. And bilious vomiting is abnormal, and that needs to be evaluated um, pretty closely. Adequate digestion and absorption is essential for newborn growth and development. So if they are not digesting their food, if they are not absorbing the appropriate nutrients from what they are being fed, they are not going to grow and develop normally, and we're not going to see what we expect. Postnatal growth should be parallel to intrauterine growth, meaning the baby should grow around the same rate as they did in utero. And we know that everybody is different. Some people grow a little slower than others. Some people put on weight a little faster than others. But what we should see should correlate in a newborn very closely with how they grew in utero. In the first 5 to 10 days after being born, newborns will lose about 5 to 10% of their birth weight, and that is okay. But when it becomes more than 10% of their birth weight in that time frame, then we need to start looking at other things like, are they being fed enough? Do they need a higher calorie formula? Do we need to supplement breastfeeding? And if they do not lose weight, then that can indicate that there's some type of fluid retention going on. So we need to be assessing the bladder. We need to be checking heart sounds and lung sounds. We need to be assessing fontanelles to make sure that we aren't filling up with fluid somewhere that we shouldn't be. Because we expect them to have this drop in weight, and that's okay as long as it's not more than 10%. Newborns are typically weighed, they're at delivery, and then they are weighed. Usually they do weighing in the morning at the beginning of the shift. So either the morning shift will weigh all the babies, or either night shift will weigh the babies very early in the morning. We try to do it at the same time every day, just like you would for your heart patients or any of your other patients. And we weigh them with no clothes and no diaper to assess this while they're in the hospital. And then after that, typically newborns will have a follow-up appointment with their pediatrician after discharge, either 1 to 2 days after delivery. So these guys are going back to the doctor very soon after they are discharged home. And part of the reason for doing that is so that we can make sure that they are adapting to extrauterine life appropriately. So respiratory wise, cardiac wise, everything is going well. But also we're rechecking the weight at that visit to make sure they haven't lost more than that 10%. And if they're bordering on the line of losing too much, then those individuals may have to come back to the doctor's office in another couple of days for another weight check. Term newborns will usually pass their meconium stool, their first stool, within the first 8 to 24 hours of life. If they do not pass meconium by 24 hours, we start thinking about possible diagnoses such as cystic fibrosis, and there are some other ones, but that's a main one, or possible blockages or strictures, problems with the bowel. But we expect it to happen by 24 hours. They'll have that meconium the first time, and then they'll have transitional stools for the next day or so, and it's partly meconium and then partly fecal matter. So it can range from in color and consistency and stickiness depending on how much meconium to fecal matter is there. But after that, then we have bowel movements that are entirely fecal. Breastfed stools are very pale yellow or pasty green, and they may look like they have seeds in them, and that's okay. Breastfeeding stools are much more liquid and typically happen after every single feeding because it's so digestible that they'll feed and then they'll poop. That's not the case for formula-fed babies. Formula-fed babies have stools that are less pale. They are what you um, they are more towards what you have observed from a pediatric standpoint. They're just they look more fecal than breastfed ones. And they also smell. Breastfed stools are odorless for the most part. They don't have a strong kind of stinky smell to them, but formula fed babies will have um, more of a stinky smell. Um, what else do I want you to know about that? I think that's enough about diapers. Other than formula fed babies will not have as frequent stools and they're not as liquid as the breastfed ones. And you have to teach parents this because, especially if they're a first time mom and they're breastfeeding, when they go home, they change their first diaper and it looks weird. It's bright green or it's bright yellow and it's got little seeds in it. They might think that there is something wrong, and that is not the case. We have to tell them um, that it's okay and it's normal. Frequency of bowel movements for newborns will be individualized just like they are in adults. So some babies, breastfed ones, might poop after every single feeding, but there may be some that only poop every 2 to 3 days, especially if we're talking about formula fed babies. And as long as the bowel movements remain soft, the newborn doesn't seem constipated, is not showing you signs of being uncomfortable, like drawing their legs up to their abdomen, crying, a distended abdomen, then that's okay. From a urinary standpoint, the newborn's kidneys are um, less able to concentrate urine than a pediatric person or grown up. And because they have a limited capacity to concentrate urine, and they also have a low glomerular filtration rate in, compared with adults, it limits their ability to be able to reuptake water um, and to in order to prevent dehydration. So they are at a greater risk for dehydration because of that inability to concentrate urine. Um, Also, they have really short and narrow tubules in the kidneys. So that also adds to their inability to concentrate urine as fully as we would like for them to be able to do. And they typically can't do that until about 3 months old. Most newborns will void within 48 hours after being born. We like to see them void in 24 hours, particularly if they are being discharged home. If a newborn has not peed, we would not send them home. Um, if they have not peed by 48 hours, then we need to be assessing how much they're taking in terms of fluid. If their bladder is distended, do they seem restless? Do they have some symptoms of pain? Um, So big key points here are that they cannot concentrate urine. They have a limited capacity to do that in terms of partly because of a structural issues, and that low GFR um, makes them unable to dispose of water rapidly as well. So we have patients, or we have patients that we're taking care of who are, number one, at risk for dehydration because they can't concentrate urine, and number two, they have a low GFR, which puts them at risk for overhydration as well. So we have to be very careful about giving them fluids, particularly if we're talking about IV stuff, because they're unable to dispose of water very quickly. So they will overload on you. Their initial bladder volume is somewhere between 6 and 44 milliliters. And unless there is edema present in the newborn, a normal urinary output is often limited until their fluid intake increases. So you think about your breastfed baby who's only getting colostrum for the first 3 days. You might have a very small amount of urinary output, but we definitely want to make sure that they void before they go home or before they're discharged there. Um, During the first 2 days after birth, many of them may void anywhere from 2 to 6 times a day and have an output of about 15 milliliters. But after that, they will void anywhere from 5 to 25 times every 24 hours and in a greater volume. After the first void, urine may appear really cloudy with a very high specific gravity, and that will start to decrease as they begin to take in nutrients and they begin to bottle or breastfeed. Remember that they don't have a really great ability to concentrate their urine. So at that first void, you have some concentrated urine, and but you're looking at mostly what they are excreting is amniotic fluid and things that has been in there in utero. Pink stains on the diaper can be caused by urates, and they typically don't have a you don't even need to worry about that, but I do want you to know about pseudomenstruation. So for little girls that have a lot of circulating hormones from their mom, can have a discharge that is bloody or even a whitish kind of discharge, and it's related to that withdrawal of maternal hormones. So if we see that in the diaper, we don't tend to be very alarmed, but parents can get very alarmed if they see blood in their baby's diaper. So we want to teach them that pseudomenstruation can happen in little girls sometimes. During the early neonatal period, urine is really straw colored and doesn't smell very much. But after that, you will see that it's a little less concentrated and will start to smell more like what you expect. From an immunologic standpoint, newborns have limitations in their inflammatory responses that make infections much harder to recognize. Um, Typically, in an adult patient or pediatric patient, you expect to see a fever whenever there is an infection, but in newborns, that is not the case. We tend to see hypothermia, and that is a better predictor that newborn infection is occurring um, compared to hyperthermia. Their immune system is not fully activated until some time after they're born. They have a failure to recognize, localize, and destroy any type of invasive bacteria. And, and again, those signs and symptoms of infection are often very subtle and non-specific, very hard to recognize. Remember, they have a poor response in terms of thermoregulation. Their hypothalamus does not respond to pyrogens as a kid or a grown up, so fever doesn't typically happen and is not reliable in terms of um, being able to diagnose some type of infection. Only IgG crosses the placenta. So active immunity happens with when a pregnant woman forms antibodies in response to an illness or an immunization, and not just a pregnant woman, but everybody. And passive immunity is all that the fetus has whenever it is born. So that comes from IgG. and that's the only thing that crosses the placenta. So that is the only thing that a fetus has. So even though a mom may have some active immunity, that IgA and IgM will not cross the placenta, only the IgG. It's transferred primarily during the third trimester. So if you have a baby who's born prior to the third trimester, it has not had that transfer of IgG and is even more susceptible to infection because it doesn't have very much passive immunity compared with a full-term baby. Normal newborns can produce protective immune responses to vaccines as early as a few hours after birth. And the main one you have to think about here is the hepatitis B. So we can give that directly after birth. But our routine immunizations for neonates don't typically begin until around 2 months of age. And we start giving them then so that the baby can start to develop some active immunity. IgM antibodies that are produced by the fetus start that production around 10 to 15 weeks of gestation. Elevated levels of IgM at birth can indicate that there have been some type of placental leaks or antigenic stimulation in utero. And it suggests that the newborn was exposed to some type of infection in utero. So you can think about it this way. IgM is not supposed to cross the placenta. So if you have elevated levels of that at birth, it means that there was something that happened in utero that wasn't quite right. Functions of IgA immunoglobulins are not really fully understood. And to understand this information much deeper, if you choose to do that, you need to go back to your immunology concept and kind of reread up on all this IgA, IgM, IgG. But IgA appears to provide protection mainly on secreting surfaces. So the respiratory tract, the GI tract, the eyes, and colostrum is really high in the secretory form of IgA. So it can provide some passive immunity to babies through a mom who is breastfeeding. But newborns themselves don't typically begin to produce this type of IgA until about 4 weeks after birth. From a neurologic standpoint, the newborn's brain is much smaller than the grown-up one, about 1/4 of the size, and myelination of the nerve fibers in their neurologic system is very incomplete. The intrauterine experience in a fetus can affect how they respond to the external environment. They're affected by mom's nutrition, the physical environment she lives in, and behavioral responses in the neonate to stress can vary in a wide range. And again, they each have their own individual temperament. So you can have a baby who is very laid back, and you can have one who is also very active and sensitive. Factors such as exposure to intense noises or auditory stimuli can also manifest themselves in newborn behavior after they're born because they may be significantly less reactive to really loud sounds after birth if they were experiencing loud sounds in utero. But for a baby who lived in utero in a physical environment where the maternal environment was very quiet and there wasn't a lot of noise, that newborn may react much more to very loud sounds after birth. So what they experience in utero contribute to how they will react to things postnatally. Newborns cry, and that is their language. That is how they tell you something is wrong. From another neurologic standpoint, we discuss how newborns are very flexed and have hypertonic muscle tone. They're very resistant to extension. Whenever you try to pull their arms down to put a shirt on or to dress them in a gown, it's very hard to do that. They stay very hypertonic and flexed up. And that indicates that their neurologic system is doing what it's supposed to. It's well developed. For the baby who is hypotonic, that indicates to you that there is something not quite right neurologically. There's some type of insult or something's going on to cause that hypotonia, because we expect them to be very flexed and not like just laid out. When they are awake, they tend to exhibit sort of purposeless, uncoordinated movements of their extremities. And we expect that to happen bilaterally. If they're moving only one side, or they're moving one arm and not the other and both legs, then we start to think about possible birth injuries that could have occurred or possible neurologic injuries that might have happened. Their organization and the way they move are influenced by a lot of different things. Their eye movements are observable during the first few days of life, so they will open their eyes and look around. Babies can typically, newborns can only see about 8 to 12 inches in front of their face. So to encourage bonding, you want moms to hold them close so that the babies can have a good picture of their face. When they cry, we want it to be very lusty and vigorous. We want them to do a good cry. And that also lets us know neurologically that things are mature. If they have a little teeny tiny whiny cry, the parents might think that's cute, but it is not. It indicates that there could potentially be some neurological issues plus some respiratory things going on if it's immediately after birth. Growth happens in a cephalocaudal and proximal distal fashion. So they grow from their heads down and from their center outward. Muscle tone should also be very symmetric, and babies who have a diminished muscle tone or are very flaccid, they're not flexed up, they don't have that hypertonic tone that we expect, that will indicate to you that there's some type of dysfunctional process happening neurologically. We expect their deep tendon reflexes to be symmetric as well. So if you can elicit Babinski on one side, you should be able to elicit Babinski on the other side. And remember that you need to know your newborn reflexes. Performance of complex behavioral patterns also reflects neurologic maturation. And again, if you take a look at your Ballard assessment and look at all the neurological box there, you can see how you should expect a term newborn to act neurologically as opposed to a preterm newborn. Here is a list of your common newborn reflexes, and I would like for you guys to know these. Babies also have different types of periods of reactivity. So whenever we are assessing level of consciousness, we are looking for periods of reactivity related to sleep and related to being alert. And in a sleep state, babies can transition between deep or quiet sleep to active or light sleep. And during their alert states, we can see them their level of consciousness change from being drowsy to alert and quiet, to alert and active, and even to crying. Newborns tend to have a self-quieting ability. They they have the ability to self-quiet themselves. They are able to put themselves to sleep. They are able to get quiet and comfortable, typically on their own. But babies who are neurologically impaired have an inability to do this. And I'd like for you to think about your drug babies. Those guys have much more of an inability to self-quiet. They are irritable. They cry a lot, nice high-pitched cries. So they neurologically are impaired to a point that they have a problem self-quieting, on top of probably withdrawal as well. However, um, caregivers that provide a lot of stimulation and a lot of comfort for their babies. So they hold them every single time they cry, they pick them up and they hold them. They rock them to sleep so they don't have to hear them cry themselves to sleep. Those babies have a learned behavior that they need someone else to comfort them, and they tend to lose the ability to self-quiet themselves, and they have to learn how to do that again. And so it's okay to tell parents if your baby is awake and lying in the crib and they are okay and they've been fed and they have been changed and you are sure that there is nothing hurting them or wrong with them, it's okay to let them cry themselves to sleep. They are built to do that. Um, and also, if they wake up and they're lying there with their eyes open and they're looking around and they're observing their environment, we don't have to go in and pick them up and be holding them all the time. It's okay to let them lie in their crib with their eyes open and just explore visually their environment. That's very hard for parents to do because they want to hold their newborns. But whenever we do that continuously, they lose the ability to self-quiet, and then moms get stressed out because they can never put the babies down, and it's a vicious little process. Sensory capacities of the newborn: babies can see, they can hear, they can taste, they can feel. Um, they don't see very well. I remember I told you they can only see about 8 to 12 inches in front of their face when they're born. So it's important to keep things close to their face if it's things you want them to see, like the mom or the dad or the brother or the sister. And also, in terms of colors, they're very interested in high contrast objects and patterns. So if you've got a book that you're reading to them, things that are very brightly colored with lots of contrast and patterns capture their attention. From an auditory standpoint, they should be able to hear. Kids who lack auditory development have an increased risk of sudden infant death syndrome, and most newborns will get a hearing screen before they are discharged home. Newborns are able to distinguish their mom from other people because they can smell her, particularly breastfeeding babies. And they explore their environment also through taste and through sucking. Newborns will respond differently to different tastes, and when they breastfeed, babies who do that will suck in very short, quick bursts with frequent pauses, until the mom has a letdown reflex, and then you will see their sucking change to a long, more drawn out suck. when they're awake and they're hungry, they have rapid searching motions that occur because of the rooting reflex. So that's one of the hunger cues that you would want to clue your parents in and educate them about. And babies also will use non-nutritive sucking as one of those self-quieting activities. So if you have, this is why sometimes you will find babies who suck their thumbs to go to sleep, or kids who have to have a pacifier to lay down and be quiet and take a nap. That's how they self-quiet. Newborns also have the ability to feel. They are very sensitive to being touched and cuddled and held. They like that. Um, so some of the ways that we can soothe them, um, as opposed to holding them all the time, or doing things like swaddling them, if you know how to do that appropriately. We tend not to swaddle newborns past 4 weeks because of the risk of SIDS. And if parents are going to swaddle at home, we encourage them to use a swaddler that has Velcro instead of trying to do it with a blanket unless they're very good at it and they know how to do it, such as a nurse who works in a nursery. Um, Placing a hand on their abdomen will also soothe them, and holding their arms to prevent a startle reflex. That's a big part of swaddling itself. Um, so newborns will wake themselves with a startle reflex because they have these uncoordinated movements that happen, and if they become jerky, they can startle themselves awake. So holding their arms close to their body in that flexed position helps them to self-quiet, and it also keeps them from being able to extend their arms in that startled position and waking them up. So that's one reason also that swaddling works. There are times in the newborn period where we have alterations in the newborn, and there are a lot of factors that can influence the outcomes of neonates who are at risk. So we've talked about several of them even prior to now, but birth weight, we know, is one of the #1 predictors of how well a baby is going to do once it's born. Babies who weigh less than what we expect, who are small for gestational age, who are premature, those babies tend to not do quite as well. Babies who are premature, the type and the length of an illness that they might be experiencing, or even that mom might have experienced, environmental factors, and separating them from mom can also influence outcomes. Your at-risk newborn is one that is susceptible to illness or death because of a dysmaturity, an immaturity, physical disorders, complications that happen during or after birth. And your at-risk newborn is most often a product of something that happened because of a high-risk pregnancy. So we've had a mother who was a low socioeconomic status. We had a mom who had limited access to health care, or she didn't get any prenatal care. She exposed herself to some type of environmental dangers like drugs, or she is in a work environment that exposed her to teratogens. She had pre-existing conditions such as gestational diabetes or pregnancy-induced hypertension. There can be other maternal factors such as congestive heart failure, or maybe mom is a type 1 diabetic. Other medical conditions that are related to pregnancy, and there are complications such as abruptions or previas or intrauterine infections. All of those things contribute to a newborn at risk. And because all of these factors are associated with prenatal risks, usually we can anticipate if the baby being born is at is at risk, and we can sort of put together a plan of care even prior to them being born so that we can monitor certain aspects of their care more closely, or we can start treatment early. Like a prime example of that would be a mother who got no prenatal care and didn't get a group beta strep swab. So we didn't have a GBS status on her. Well, because we know that moms with no prenatal care don't get a GBS, and we have no status for her GBS condition, we can go ahead and prophylactically treat her during labor, because what we know is if the mom is positive, it puts that newborn at a greater risk for contracting GBS. So we want to treat her prophylactically in labor. And then we would assess the newborn very closely for signs and symptoms of infection afterwards. Now, and we may even give that newborn some prophylactic antibiotics because we don't know the status of the mom. So we know that labor and birth itself is a very unpredictable process. We don't know what's going to happen. We know how to manage certain alterations that can occur. And so we do our best through electronic fetal heart monitoring, through APGAR scoring, to identify newborns that are at risk and may have an alteration. Gestational classification also helps us with this because we know that preterm babies don't do as well. And preterm is considered less than 37 weeks. Term is anywhere between 37 and 41 weeks. And postterm is for your babies that are 42 weeks or greater. Late pretermers are a subgroup of preterm babies, and those guys are born between 34 and 37 weeks. They typically tend to do pretty well from a respiratory and a cardiopulmonary cardiology standpoint in terms of adaptation. But they still are preterm, so they still have a lot of immaturity that your term newborn has developed. So even though they do fine respiratory wise, there are other issues that can arise if you're a late pretermer. And the neonatal mortality risk will decrease as their gestational age and their birth weight increases. And so that's important for nurses to understand as well. So how do we take care of these guys? From a healthcare standpoint, I don't think there is one area that we work where we do not collaborate with someone else for something else to take care of a patient. So we all work together to take care of newborns especially. We have pediatricians, we have neonatal specialists, we have nurse lactation consultants, we have audiologists, we have respiratory therapists, we have the lab. The list goes on and on. What we do know is that newborns have a really critical period after birth that happens in the first 4 hours of them being part of the extrauterine world. And during that time, they need some drastically increased assessment time. They need the collaboration of a team of people who can care for them if things go south. We have assessments and interventions that involve all of the body systems. So if you have a lung issue, then you want respiratory therapy at your bedside. Care is divided typically for newborns between three sort of categories. So we have initial care, which means the care that happens right after birth, and subsequent care, which means the rest of the care we provide throughout their hospital stay. And then we have preparation for discharge. And it's hard to separate the preparation for discharge because we start preparing moms and dads to take their newborn home before the newborn ever arrives to the extrauterine environment. If we have a chance during labor when she is teachable to teach her as a nursery nurse, we do that because we have a very short window of time to prepare these people to go home and care for a human. Um, Complications that happen in the newborn world might require referral to additional specialists, and a lot of the times you cannot just refer to a specialist down the road um, because very many people work on adults and specialize in adult health care, but very few people specialize in pediatric and newborn specialties. So oftentimes kids who have problems end up having to go farther away for care to big tertiary care facilities that staff specialists for newborns, particularly when we begin talking about things like congenital heart anomalies, gastroschisis, and that kind of stuff. Your nursing process has to include a plan of care that is based on a thorough and ongoing assessment for the newborn. And you as the nurse, have sort of three really primary concerns in a newborn uh, person. You want to make sure thermoregulation wise that they can support those efforts. You want to make sure that from a respiratory standpoint that they are adapting well to the extrauterine environment and that their cardiac function and their cardiac adaptation process is also moving along as expected as well, because any one of those issues, an issue in any one of those three areas will cause everything else to be totally out of whack. So the initial care of your newborn begins immediately after the baby is born. We want to maintain a very clear airway for these people. So we might place them supine with their head down or to the side, or either we'll lay them on the mother's abdomen. If they're having trouble, we may place them under a radiant heat warmer that has been pre-warmed. We can maintain them in sort of a modified Trendelenburg position that helps with blood flow. We want to suction them with a bulb syringe. We want to wipe their mouth and their face. We want to dry them off and remove the wet blankets. If they need some support in terms of oxygenation, we can give them a little blow-by oxygen. And what that means is that you just really, truly take the oxygen tubing and blow some oxygen by their nose. We don't hook it up. We don't put them on a nasal cannula. We just hold the oxygen in front of their face. That's called blow-by. And sometimes we have to do that for babies who don't want to pink up very well. We can maintain them in terms of warmth by giving some warm blankets and using skin-to-skin contact with the mom. But if the mom is wrapped up in a blanket and then you place them on mom's chest, that baby will not get the benefit of radiant heat from skin-to-skin contact with the mom. So making sure that the baby is undressed and truly skin-to-skin is important if you're using that type of intervention. Again, we can suction the mouth and the nose as we need to, and specifically we focus on the nose because we know that newborns are obligatory nose breathers. And most immediate care can be accomplished while the newborn is in mom's arms or dad's arms. And we don't need to remove them from that skin-to-skin contact as long as they're doing okay. Um, but if you have a newborn who is more sickly and needs some serious interventions, then those individuals may have to be moved to the nursery where you have a more supportive equipment like ventilators and oxy hoods and that sort of thing. And unless there's a medical complication, we should do the assessment and do our shots and drops while the baby's on the mom's abdomen or chest because we want to promote parental attachment. And we know in that first 30 to 60 minutes after birth, babies are highly in a period of high reactivity. So they're going to respond, they're going to bond, they're going to be more likely to feed well and adapt. Ooh. Sorry, guys. We also want to make sure that we're promoting thermoregulation initially as well. So making sure that we're assessing temperature, that we cover the baby's head and postpone their bath until their temperature is at whatever the hospital policy says it has to be to give a bath. Typically, we go 97 degrees and above. And we want to make sure that everybody is implementing really good hand washing techniques as well, not just the nurses and the healthcare staff, but family members, mom herself, um, and do a lot of teaching surrounding that. You need to know how to do an APGAR score, and APGAR scoring looks at 5 specific areas of assessment for the newborn. We look at heart rate, their respiratory effort, muscle tone, and their reflex irritability and skin color. And each one of those 5 areas can get a scoring of either 0, 1, or 2. What we hope it is at 1 minute of age is somewhere between 7 and 10, and that indicates there is a good condition. That newborn is adapting to extrauterine life well. If it is less than 7 at a 5-minute time frame, then we are going to repeat our APGAR score every 5 minutes up to a 20-minute time frame. And we potentially may need to be implementing resuscitative measures during that time. A score that is less than 3 at 5 minutes of age correlates with neonatal mortality. It means that that baby is likely to not make it if our score is less than 3 at 5 minutes. Clamping the cord happens shortly after delivery of the baby. Clamps are placed some after the vessels have been identified. We typically place it around half to an inch from the actual abdominal cavity. And we must be sure that we have not clamped the abdominal skin. We can usually remove the umbilical clamp around 24 hours, but we would never remove it unless the cord is completely dried out. Delayed clamping is a thing now and may have more benefits to the neonate than actually immediately clamping the cord as soon as the baby is born. Delayed clamping for around 30 to 60 seconds will help to increase blood volume in the baby. It will reduce the need for blood transfusions should the need arise. It will decrease incidence of intracranial hemorrhage in the baby and lower the frequency of iron deficiency anemia as well. But there are some concerns around delayed cord clamping if it's not done within the appropriate time frame. Polycythemia can occur, and typically that's benign. It doesn't cause very many problems, but it can also cause delayed resuscitation of a newborn who is in need. And it can also interfere with cord blood banking if the parents have requested that. So just something to be aware of. It's also important to teach parents how to take care of the cord and let them know that they are not supposed to remove the clamp until the cord is dried out. We want them to keep that umbilical stump clean and dry, and make sure that it's not soiled after diaper changes, because we don't want to create an environment that could breed infection. Banking cord blood has also become a very popular thing, and there's not much that I really want you to know about cord blood banking, other than the fact that cord blood banking is done at parents' request, but they have to buy the kit themselves. They choose a company who specializes in cord blood banking, and they bring that kit with them to the hospital. The physician is responsible for drawing the cord blood and placing it in the appropriate vials or tubes or whatever comes in the kit. And the parents are responsible for sending it back to wherever it is supposed to go. It is very expensive, and most hospitals do not offer banking services. It is something the parents have to do on their own if they choose to do this. There are a couple of different types of cord blood banks. There are public banks and private banks. Public banks will allow that cord blood to be given to anybody in need. And private banks are banks just like your bank account. You are the only person who can get your money out of it. And a private cord blood bank is specifically held, that whatever you bank is held privately for your family or for your use. Continuing on with initial care of the newborn, it is very important to make sure that identification of your newborn has been taken care of before that newborn is ever removed from the room. So almost immediately after birth, we are applying bands. And bands come typically in a set of 4 that have identical numbers. We place one on the infant's wrist and one on their ankle, along with a security monitor that will help hopefully prevent that baby from being removed from the OB unit. The mom gets a band, and the partner of her or whoever she requests gets the other band with an identical number. And in most facilities, only the people who have the band are given access to that newborn from an unlimited standpoint. And almost everywhere now will attach that alarm to the ankle band, or they even have a separate band that goes to the ankle. There are also additional security measures that are put in place in most facilities. All staff that work in that area must wear their appropriate identification at all times, and in most places there's a pink badge or a pink border around the badge for individuals who work in that area. So even other hospital staff within the facility should not be allowed to go into the room and remove a newborn from a mom or a family. And we should educate them on that. Only allow someone who has this pink band on their badge to take your baby, or who has the fully pink badge to remove your baby from the room. Letting them know that people who work on that specific unit have that particular type of badge is important. We want them to keep the baby on the side of their bed and away from the window. We want them to make sure that whenever the baby is returned to the nursery, if there is one for the baby to be returned to, that identification is being checked whenever she picks the baby back up. Also, if she's going to take a shower or take a nap, to make sure that she's aware of safety measures and asks the nursery staff, if there is a nursery, to come and get the baby so that the baby is not left alone in the room unsupervised. Many times people who abduct babies will pose as medical personnel, so it's important for them to know that as well. I am not going to elaborate on assessment. I'm going to allow you guys to look over assessment on your own. So whenever I record lecture 3 for PowerPoint 1, individual module 6, we are going to pick up at the diagnosis and planning portion of the nursing process. I do want to show you one slide. So here is a quick little rundown of newborn assessment, and it gives you a pretty good overview of specific assessment things that we are looking for and what are normal for most of those areas. I placed this on here because I thought it was a good little overview, and I hope you find it helpful. All right, so we will pick up in the next lecture, starting with the diagnosis portion of the nursing process. And I'm just going through my assessment notes really quickly to make sure that I don't have anything that I want to elaborate on in terms of assessment, and there's not. Okay, so I will be back in the next video. Thanks for listening.